we'll talk about implant design and how this relates to robotic surgery. I've really enjoyed the discussion at this point and how all of us have approached these same problems of registration, planning, and bone preparation with different technologies. So my disclosures haven't changed, but I would also disclose that I'm 54 years old and I have an arthritic knee and I still have my ACL. So I got involved in designing the Journey implant in 2004, and I wanted to make an implant that I wanted to have in my own body. So we'll talk about the Journey 2 implant and how Corey is used to put these implants in place. I surf, all my patients surf, and surfing is a big test for a total knee. You have to bend the knee to 145 degrees or 150 degrees to pop up on the surfboard. The knee must be perfectly stable in mid-flexion. 30 to 90 degrees is where we are most of the time, and you want to retain proprioception for difficult maneuvers like riding a barrel. You can't do this with traditional implants. It's just not possible. We talked about how this flat joint line really is not anatomic. The normal joint line is oblique, and that is necessary for normal ligament tension. The IB2 design and every total knee design on the market keeps your femur posterior on the tibia. And this is intentional to enable deep flexion, but it puts your quadriceps at a disadvantage, so you never get great quad control. And then if you have a CR knee, that you have this paradoxical motion where the femur slides anterior as you go in and out of flexion, and that doesn't feel very good when you're doing high-level activities. Or if you have a PS-type knee, the femur is locked in this posterior position, so you never get great quad function, again, necessary for sports. So if we use nature as an inspiration, and the dolphin's fin was an inspiration for the surfboard fins on the thrusters, we did the same for the total knee. And in the early 2000s, we got a lot more information available to us by collating CT scans, MRIs. We could do virtual MTS testing. We can incorporate ligament function. And the goal is to make an anatomic knee implant that restores pre-arthritic joint shape and alignment with the goal of preserving all of the ligaments in the knee. And it's a family of implants. So the first implant design was a bicruciate substituting total knee. Then we added a CR type, and then the XR is the bicruciate sparing design, and we also included unis and PFJs in the whole family. So any implant you use, you should understand the design philosophy. And basically with the Journey 2 knee, you want to make balanced flexion and extension gaps that are 19 millimeters. And these cuts on the distal femur and proximal tibia are going to be perpendicular to the mechanical axis, and then we externally rotate our cuts so we get parallel boxes in flexion and extension. So you have these rectangular gaps, and this is pretty typical of how we do our total knees. What's unique about the implant is that it's thinner medially and thicker laterally. And this helps restore the oblique joint line. And the femur, again, is thicker medially and thinner laterally. So this helps your ligament tension tremendously. And this is what we are trying to do with kinematic alignment, where we're adding valgus to the femur and adding varus to the tibia. But this ends up internally rotating your femoral component and does weird things to your patellofemoral tracking. So I think it's hard to achieve this goal routinely and get good function. So the femur matches the anatomic contours. It's a different radius of curvature medially than laterally, just like a normal knee. The tibia component is concave medially and convex laterally like a normal knee. And this helps normalize ligament tension and also helps drive posterolateral rotation, normal kinematics as you go into flexion. So this is a complex graph, but worth digging into. The blue line is the MCL tension. So it's tighter in extension than in flexion. The orange is the Journey 2 MCL tension. So it parallels the joint line, and the MCL gets looser as you go into flexion. With the traditional implant that you have this flat joint line, the MCL just gets tighter and tighter as you go into flexion. So if you want your knee to bend 135, 145, you have to put it in a little bit loose. This becomes a big problem on the lateral side. The LCL strain, again, tighter in extension, looser in flexion. Journey 2 matches native. But with a standard knee implant, you're very loose the whole way through. And if you put it in extra loose so your MCL is not too tight, then the knee feels very sloppy. And this is a major reason for revision of mid-flexion instability, and why 30% of patients don't like their total knee. So the Journey 2 knee gives you this oblique joint line, so it reproduces that oblique anatomy, and also keeps your femur anterior where it's supposed to be over the tibia, and that helps your quadricep function and patella tracking. So if you look at normal knee kinematics, it's pivoting and has this posterolateral rotation as you go into flexion, the Journey 2 knee does the same thing, and the rotation also occurs at the correct timing. And this knee gets deeper flexion more easily. When I changed to this implant, my physical therapist I work with closely asked me what I was doing differently. And he said, your patients are moving easier, they're moving faster. In my post-op protocols, I don't do any formal PT for the first 2 weeks. I just want the knee to settle down. The patients get their motion much easier. My instance of manipulations is hard to remember the last time I did one. This is a mature implant. The Journey 2 has been around since 2011. There's over 200,000 implantations, has a 5A ODEP rating. We have some studies out there that show you that compared to the Legion, which is a more traditionally designed implant, this was Hospital for Special Surgery in New York, 23-degree range of motion improvement at 1 year and improved knee society scores. So the knees function better with the Journey 2 knee, and it's very durable. So this is a study looking at registry data. So 5-year revision rate was less than PS implants. And if you look at these very active young patients, revision rate 3.1% versus 7% in the registry. So very durable, and less than 1% required revision at 6 years. So if you put the knee implant incorrectly and don't have an infection, it should be very, very durable. So this is a typical patient. He's 72 years old. He has a mild varus deformity. My patients definitely present earlier than what you're used to seeing. He has a slight flexion contracture. I set up the room, as I showed you before, with the Cori device across the table from me. My assistant is positioned just cephalad to me through the whole procedure. I do not apply a tourniquet. I do all my cases through a subvascular approach. My patients are primarily outpatient surgeries. When I make my approach, I don't do a big ligament release. I just do enough to get the work done, but I do carefully remove all the medial osteophytes in this varus knee. Helps with two things. Helps the robot get a better estimate of the size, medial lateral, and also helps detension the MCL. The system of Cori allows you multiple surgical preferences. I collect joint laxity because I use that to help me with my gap balancing. Femoral rotational access we'll talk more about. You can set your tibia resection depth or anterior or posterior reference. So the computer will automatically put the implant at 3 degrees external relative to the PCA unless you have a large deformity, in which case it'll trigger you to manually define the PCA. And you can use Whiteside's line, or you can use the epicondylar axis. As mentioned before, you can have lots of options here. We want to get the mechanical axis, so we start by defining the center of ankle by touching the medial and lateral malleoli. We identify the center of the ACL footprint, center of the femur at the trochlea, and this is how we collect those data points. We rotate the hip to get the hip center. So total time for data collection and registration is very short. And now we have the mechanical axis of the femur and the tibia. We know what the patient's starting with, and then we can dial it in to exactly what we want postoperatively. You define the initial range of motion, and this is how long it takes to register the range of motion. You want to know where you're starting and what you have to correct. The digital mapping we talked about before, it's very quick, very precise, takes about 40 seconds. I also add special points. I like to make some marks on the anterior cortex to make sure I know where that is and avoid notching. I draw in where I think Whiteside's line is. I manually define the AP axis of my femoral component to be perpendicular to the posterior condylar axis. I agree with the earlier speaker that it's challenging to identify the epicondylar axis. So I start at 0 and then I manually externally rotate the component until I reach the number that I'm looking for. Tibia registration, again, very quick, around the outside of the rim and then coloring the surface to refine the model. So the initial implant position by the computer is perpendicular to the mechanical axis of the femur and the tibia. And then the surgeon will modify the plan. And typically, I'll run through this plan slowly and in detail, but it takes me a minute to plan a knee. And my registrars take longer and I can always correct their plan. The idea of an anatomic implant is that it functions like a pre-contoured plate. If I get this plate correctly positioned on the lateral cortex, then the rest of the fracture will line up. If I get my less affected side perfectly balanced, then I know that my joint surface is corrected on the more affected side, and I can adjust anything residual with soft tissue balancing. And ideally, we want to minimize our soft tissue balancing, but in severe deformities, it's unavoidable. So we have an algorithm where we stepwise add correction, adding varus, for example, to the femur as the deformity gets more severe. We're cautious about adding varus to the tibia because you already have 3 degrees of varus built into the tibial polyethylene. So this is our basic algorithm, and we're staying very well within our safe zone of plus or minus 3 degrees. And since we have sub-millimeter accuracy with our milling tools, we're not having the errors that you can have with a saw blade. If you dial in 3 degrees, that's what you're going to get. So initial implant placement is here. So the first step is verifying that I like the size, and I'm going to pick the biggest size I can without medial and lateral overhang. And then I'll set my distal femoral cut angle. So this patient had a 9-degree varus knee, and based on our plan, we're going to goal of adding 2 degrees of varus to the femoral component. So we do that by clicking this button here. But it looks like we're going to add too much material back laterally, so we need to move our femoral cut more proximally, and that matches the lateral joint line. So we've adjusted our extension gap shape. Now we adjust our extension gap size by moving the femur proximal or distal as needed. And then we go to the top right-hand screen, and we see that the femoral component is positioned 90 degrees to the PCA. So I'm going to add 3 degrees as a starting point and see where we end up. In this case, we have a 3 millimeter difference in our posterior femoral cuts, and that's appropriate for 3-degree rotation. And with different implant designs, you may not externally rotate as much, and I'll show this to you later. But you have this notch warning, and you can see that our femoral component is really too posterior, so we're overstuffing our flexion gap and not restoring posterior femoral condylar offset in the sagittal plane. So we just have to move the femur anteriorly. So now we match the posterior femoral offset, and we can verify our component position on this 3D model, so you can toggle back and forth. Now we go to the tibia. The tibia is almost always one size smaller than the femur for this system. We center the tibia on the position on the tibia bone model, but it looks like we're going to lower the joint line. We need to move the tibia approximately so it matches the less affected joint line. So now we've done that, so we've matched the joint line, and we can set the posterior slope. For this implant, it's indicated to be at 3 degrees. Now we can collect our gap information. So I just basically put a Z retractor in the knee and range the knee with a strong valgus stress, and I range the knee with a strong varus stress, changing the position of the Z retractor. And this is how long it takes to gather that information. Again, registration doesn't take hardly any time. And now we have this gap information, and the purple is lateral, the orange is medial, and it looks like I'm loose laterally in extension and loose laterally in flexion. So the easiest solution for this is to cut a little less tibia. So now our gaps are more closely balanced, but I'm a little bit looser in extension than I am in flexion. So one option is to cut a little less distal femur, and that's one option, or you can move the femur anteriorly to loosen up the flexion gap, or even downsize the femur. So I move the femur anteriorly here, and now my gaps are within a 0.5 millimeter of each other. And I have chosen a 9 millimeter poly, but in the back of my mind, I'm thinking I might need a 10 millimeter poly at the end of this case. But I'm still tight medially. What does that mean? Well, it guides our soft tissue releases for later if we need to do them. You always get soft tissues loosening up as you're making your bone cuts. So I think it's a mistake to do soft tissue releases early in the case. So again, tighten extension, MCL pie crusting, using the Cori machine for guidance of exactly how much to release. Tight medially in flexion, posterior medial capsule. Tight laterally in extension, very common for valgus knee, IT band, pie crusting. If you have to start releasing posterolateral structures, like the LCL, in a bad valgus deformity, then I start thinking about a constrained component or a hinge. So the negative and positive numbers are the result of the computer placing components perpendicular to the mechanical axis in an uncorrected position. So the gap is positive and this overlap is negative. And when you put the trials in, this is what the computer sees. And this is the output from this case. This is where those numbers came from, what it looked like to the computer. Before correction, after correction. Bone removal, again, is if you're using cutting blocks and a saw, you're taking a step backwards in your precision of bone preparation. So the milling is absolutely the best way to go. It's very efficient, 6 minutes to prepare the bone for a total knee. I don't think you can beat that with any device. Going from top to bottom. And the excursion of this milling tool is 12 millimeters, so you can remove the bone in a single pass. The tibia, we just go from the top down, front to back. The bone is removed quickly and easily, and you know when you're done with this bone preparation that you have an accurate cut. We put in our trials and we assess range of motion, and we also assess ligament balance. This graph shows me that I'm a little bit looser in the lateral side in extension and inflection, but I'm a little tighter medially. So I can pie crust my MCL and I can add a little thicker polyethylene. And again, as you're doing this release, I want to have numbers, information. I can see what's happening to my curve as I'm doing these releases, if I need to do them. In this case, all I did was I added a thicker poly, and then I had sub-millimeter gaps through the full range of motion, got my 2 degrees of varus correction. And we have all this information, and we reviewed this with the fellows as well, so they make sure they understand why they planned the case this way, what they got, and it all should make sense. This is the final outcome. I always get long leg films to check my work. This patient had an excellent result. Now, this is coming to India. This is one of my favorite operations, and this is going to be my knee when it's my turn, is a bicruciate sparing total knee. So this is a relatively unconstrained polyethylene on the tibia side, and it's built like a medial uni and a lateral uni connected by a metal bridge, a very durable implant. And it's the ligaments that drive this posterolateral rotation as you go into flexion. And you need a robot to do this operation because you want to mimic the prearthritic joint shape and alignment and maintain the joint line precisely. And this is the kind of patient that we deal with in the US. You look at his knee and you say, where's the arthritis? This guy's complaining bitterly. He's like, my knee swells up all the time. I'm miserable. I've injected it. I've done an arthroscopy. And he has exposed bone. So I have to hit it out of the park. I have to do an excellent job for this patient so he can surf better after the surgery than he did before. And this is his plan. And you can see here that we're really looking at the 3-dimensional model of the knee. We're matching the lateral bone shape, and we're adding material back medially where there's wear. And this is why digital mapping is so critical, because I want to match the cartilage surface. That's the real joint line. I'm not externally rotating as aggressively. I just want to match his posterior condylar axis, match his joint line precisely, and I even have to match the rotation of his tibia so that we are internally rotating this component, relatively speaking, to maintain the ACL. And you can see here, like we talked about earlier, this knee is opening up laterally as you go into deep flexion like a normal knee. So this is why you want to have all this information available when you're planning. This is what the implant looks like in real life. You have the bone island preserved for the ACL insertion. You have plenty of room to clean out the back of the knee. And this is the x-rays. It's a very bone conserving operation. This is him going home the same day. So with the kinematic implant design and computer-aided design, planning, and CNC machining of the bone, we can really get excellent patient outcomes. This is our patient back surfing, so he's happy, I'm happy, and I think that the combination of the implants that you have really should help drive your decision for the robot. You want to make sure that the implants that you're using are the most advanced, durable, and kinematic implants available. Thank you very much.